This is DuBois Bowman, Dean of the University of Michigan School of Public Health. I am also a professor of Biostatistics. The world has been significantly impacted by COVID-19, and things are still rapidly evolving. Most of us learned of the virus in late December 2019 and early January 2020. On December 31st, 2019, the World Health Organization reported 27 cases of pneumonia from unknown causes. The cases were confined to the city of Wuhan in the Hubei province of China. By late January, a research team reported that the pneumonia cases were largely due to complications stemming from a novel coronavirus. Initial human transmission probably occurred in late November, early December. Since that time, the global reach and exponential growth of this virus has been astounding. As of today, March 19, 2020, there are over 245,000 confirmed cases worldwide. These cases reach across 179 countries and territories. There are nearly 14,000 confirmed cases in the United States, spanning every single state, and Michigan has 336 confirmed cases. As others will discuss, these figures likely only represent the tip of the iceberg. The U.S. is still very much in the acceleration phase of this pandemic, and widespread testing will likely reveal significantly greater spread of the virus than what is currently known. During an evolving pandemic, I'm grateful to have colleagues who specialize in infectious disease research and related areas, including some who've done work on COVID-2 or SARS and influenza. It is indeed a privilege to be on a campus with public health experts, a world-class healthcare system, and other colleagues across campus whose expertise can help guide our decision-making. This has been an incredibly challenging time for society, with major disruptions across virtually every sector. In higher education, including on this campus, we've already faced many important decisions and will confront many others. What should we expect longer term from COVID-19? And what are the implications for our campus planning efforts? Topics such as student enrollment, alternative modes of delivery for instruction, and our preparedness to transition quickly and at high quality. Student support services, such as mental health, technology needs, and the ready availability of testing for University of Michigan students. Healthcare system preparedness, research enterprise impacts, and the university's breadth of global affairs. A public health approach to prevention and health equity through infectious disease modeling, intervention, and communication, coupled with a robust medical response, can help to guide our efforts to slow the spread of this virus for all.
I'm Sharon Kardia, Associate Dean of Education at the School of Public Health. A set of School of Public Health faculty gathered together over the last several days to put together some basic knowledge as well as the emerging information on this particular pandemic. The materials that are represented here also come from Joe Eisenberg, Chair of Epidemiology, Emily Martin, an Associate Professor of Epidemiology who studies influenza and does surveillance for the state and works with the CDC on some of that surveillance. Peter Song, who's a professor of biostatistics, whose lab has developed some ways in which to model the data and the emergence of infection in different countries. David Hutton, who's an associate professor of health management and policy, who conducts research on infectious disease policies and cost effectiveness. Laura Power, who's a clinical assistant professor of epidemiology and internal medicine, and her specialty is in infectious disease. Aubrey Gordon, who's an associate professor of epidemiology who focuses on influenza transmission and vaccination and is currently studying the COVID-19 at the request of the NIH. And Allison Miller, who's an associate professor of health behavior and health education who's helping us to understand some of the issues with social distancing and the risk and resilience of this practice for students, staff, and faculty. So in this presentation, we're going to go through a wide range of things. We're going to talk about what do we currently know, how to think through the U.S. situation, some ways in which to think about transmissibility and the way in which that information can help us predict what we might be able to do to flatten the epidemic curve. And then we're also going to talk a little bit about the testing situation. It's top of mind for people, whether or not we're actually getting good information by the tests that are being used and the frequency at which testing is being done. And then some things that I think are also on people's minds, like when might we resume, and are there implications of social distancing that we should be aware of? So what do we currently know? Well, we know a fair amount about the disease trajectory. So when an individual is exposed, the virus incubates within inside of them. It seems like the average amount of time from incubation to the first symptoms is about 5 days, but it really can span between 1 and 14 days on average. And there are certainly some outliers to that number, but that's about the range in which people are actually probably not aware that they've even been affected. After the symptoms arise, and those symptoms are things like fever, cough, fatigue, and there are some other sort of symptoms that people can also experience, like sore throat, headaches, joint pains. Sometimes it can get quite severe, and from the China CDC, for people that were hospitalized, it was a 12-day course for people that had basically gone into the severe form of this disease. What we learned from that whole experience was another important key fact, and that is that people actually can be infectious not only when they actually have symptoms, but a couple of days before they have symptoms, so pre-symptomatically. This is very important for the spread of the disease, basically underneath the radar of what would be typical symptoms, and something that people really need to pay attention to. In the right-hand corner, we also have a nice little chart that demonstrates the frequency of different, experiences of having the infection. So about 5% of people in China had a very critical case, sometimes resulting in death. 14% had a very severe set of symptoms, but about 80% had mild symptoms and really kind of resolved over time. One of the big missing issues or big missing categories is how many people actually were exposed and were asymptomatic and could be spreading it, but may not be, because basically the ability to spread it to others is going to be in proportion to the amount of virus that somebody is producing. And when you're asymptomatic or mild, it's not nearly the same as when you're very severe or critically in the throes of fighting off this virus. Another big set of learnings from the China CDC's collection of data on the first sort of 40,000 some cases was that there was a differential mortality by age. And in particular, very old individuals are at much greater risk of dying from the infection. Another big thing that we learned was that underlying conditions like heart disease, diabetes, chronic respiratory disease, hypertension, or cancer were also underlying sort of these increased mortality rates. And so combined, both being older and having some underlying chronic condition is really one of the things that was predisposing people to very high risk of dying from this infection. Right now, as we look across the world and we look at the statistic called the case fatality rate, that's the fraction of cases that are dying from the infection, we can see it's varying widely. So Italy right now has a case fatality rate that's a little bit over 7%, and Germany is down at 0.2%. That's a very wide range. And when we think about why could it be this different across countries, we have to think of the sources of variation, like the timing of the epidemic. If the epidemic is just starting in a particular country or location, it's not likely that we're actually seeing a huge number of cases. Also, who's been tested? If a country is only testing those that are the most severe, and then we look at that fraction that are actually dying, it can be quite high because you're not really catching any of the mild cases in the way that you're testing. Another big factor for these countrywide rates is thought to be the demographics. So how many older people relative to mid-age versus younger people does a country have? Because if there's greater mortality in the elderly and a country has more elderly individuals disproportionately, then there might be more deaths experienced by that community. Another key variable here is the healthcare capacity. We know that the severe form of the cases sort of puts people in a critical care needs situation. ICUs, for instance, can be easily overwhelmed in some countries. And if you don't have the capacity to really handle that severe case, then people are more likely to die. So these are some of the major factors influencing this distribution of case fatality rates by country. Peter Song's group, who I alluded to earlier, has taken the data that has been made available by the WHO and the DXN and made a nice graph that sort of represents what we can expect and other countries can expect in terms of a logarithmic increase. So the y-axis is a logarithmic number of infected cases, and the x-axis is the number of days since that country had 150 cases. So that's basically the zero mark in this graph. So what you can see at that sort of zero x-axis mark is this great increase, this logarithmic increase in the number of cases. And if you look at the color coding, what you can also see is at the top, the China cases level out and stay at that set of cases for a very long time. After they've leveled out, we would expect after a while that to decrease. You can also see in the sort of orange Japan that seems to have gotten on top of that logarithmic increase and leveled out earlier. And then Korea, which is in pink, that is starting to bend the curve. So the number of cumulative cases is leveled off. The United States is in black, and right now, as you can see, we're right in the midst of that logarithmic increase. In this slide, it's a slightly different statistic. It's the prevalence of the infection within these different countries. So that is actually taking the number of cases and dividing it by the number of individuals in the population. So this is a little bit different view, and one of the things that you can see if you look at the U.S. is that it's following a slightly different trend. It's not as quickly logarithmically increasing, and this could be for a couple of different reasons. It could be somewhat a reflection of our geography and our spread. We have a very large country, but it could also be a reflection of testing, that we really just don't have the same testing of cases per person that some of the other countries do, and so we're not picking it up. Overall, when we think about infection in a population, we have to remember that who we are focusing on in terms of number of severe cases, deaths, or even those with, for instance, high fever, are only the tip of the iceberg, and that there are many mild and asymptomatic cases underneath. One of the reasons why this is important is that those mild or asymptomatic cases can be a part of the reason it's spreading so quickly. I mean, most of us, if we don't know that we're sick, are going to have a lower chance of actually exposing others. But people with mild cases, for instance, that are producing the virus and having not a huge response to it, can indeed be infectious. So as we go through the presentation, we're going to talk a little bit about how would we even potentially estimate the number of mild or these asymptomatic cases. Because we're the School of Public Health, and one of the main things that we focus on is really how the distribution of disease, exposure, susceptibility changes with people's lived situations or where they work. We put in this demonstration of, for something like the pandemic, how might somebody's place where they work or they live, or their ability to stay away and social distance, or handle the psychological stress, or even things like food insecurity, access to good health providers as somebody in a rural community, or for instance, the quality of health care that might be available to them, influence their exposure, their susceptibility, or the differential consequences if they develop the disease. Overall, we certainly expect within this particular pandemic that we're going to see unequal levels of illness and death across our U.S. population, because we do indeed have a lot of heterogeneity in these basic underlying causes of disparities. Given that kind of background, how do we think through the U.S. situation? The first thing is by looking at the same numbers that everybody else does. So for instance, many of us are looking every day at the reported confirmed cases and deaths. So this is changing quite rapidly, and we've seen just in the last couple of days, the U.S. cases have gone above 10,000, and the number of deaths, here it's 160. It's actually much higher as of this recording. And Michigan, for instance, has had 80 cases and 3 deaths as of this morning, and this number is also increasing. So this seems to be, one way in which we're understanding who's infected. But there's actually this underlying knowledge, if we think about the whole iceberg, of some heuristics that we can use to estimate cases. So if we think about the range of case fatalities, maybe 1 in 100 to 1 in 1,000 being 2 good bounds to look at, we could estimate right now that the U.S. has between 16,000 and 160,000 cases. How did we get there? We took the 160 deaths and we multiplied either by 100 or 1,000. We could do the same thing for Michigan. 300 to 3,000 might be that range. If you talk to many of the epidemiology faculty that study these kind of viruses, they think that we're probably somewhere in the middle here, and that neither one of these bounds is particularly accurate to the letter, but that it's much more than what we think of in terms of confirmed cases. We also thought it was important to help people start to think about what is the population dynamics when we start to see some of these numbers, like, for instance, deaths reported. So if we think about the trajectory of disease from exposure to symptoms to potentially very severe consequences like death, that takes time. So if we see 1 death today, we have to think all the way back to 3, 4, and sometimes 5 weeks ago when the person became infected. And then if you move up to when the symptoms developed, now you actually have got the sort of full window. If we now apply some of these population concepts, like the case fatality rate of 1 in 100 or 1 in 1,000, it means that 4 weeks ago, there had to be between this 100 or 1,000 cases that were existing for the 1 death we see today. If we think about now the other information that we have, which is that this particular virus doubles on average every week, that 1 death we see today also means there's something between 1,600 and 16,000 population cases. So this, I think, we don't often, kind of consider when we see this one statistic in the news, and what does it really mean for the population burden of infection, which can be quite substantial. So digging just a little bit deeper into this thinking through transmissibility, we thought we would go over some of the key concepts in infectious disease spread. For instance, what is driving transmission? We often use a number called the reproductive number, which is a measure of spread, and it's really a product of 3 terms. First is the contact rate among individuals. This is one of the reasons people are focusing on social distancing, to drive this contact rate way, way down. But there's also the probability of infection given contact. And most of us are thinking all the time, well, how can I minimize this probability of getting infected? So hand washing, using hand sanitizers, staying 6 feet away from people. But then also the duration of the infectious period. And we put 12 days here. It certainly is going to vary from person to person. But this is the time period in which people are actively producing virus in a form that really can be highly contagious because of coughs and sneezes and other ways in which the virus is leaving the person's body. We also have on this slide a table that shows kind of the relative reproductive number across other pathogens. So for instance, measles is highly contagious. It's got a reproductive number of between 12 and 18. The virus that is underlying this particular pandemic is SARS-CoV-2, so its reproductive number is about twice what our seasonal flu is. So it gives you a kind of sense that it is very contagious for what we're used to, but it's still in the range of flu in terms of how it's transmitted, how quickly in the population. Another thing to know is that In the real world, the way that viruses is spread is not necessarily neat or easy to understand. We have often talked about the idealized situation of spread where one person gets it and spreads it to two others, and they spread it to two others, because that's the estimate that we have overall. And that's what led us to the estimate that the epidemic is going to double about every 7 days. But in reality, the way that people spread can be quite different. So what's on the right here, the data from the SARS pandemic, this is individual A, and they infected 33 people, and most of those 33 people didn't infect anybody else. A would be an example of a super spreader. And the question comes up, well, is that person a super spreader because they just like to, hug everybody and shake hands? Or is there something about the way sort of biologically the virus is acting inside of them? And there's some evidence from flu that there are super spreaders, that the virus is really sort of hyper contagious for those individuals. So if we put all of this together, kind of what are we up against if we think about the whole U.S. population? Well, we can start with the knowledge that about 80% of the cases are likely to be mild or asymptomatic, which is good news. We have knowledge that we've got pre-symptomatic transmission. That's probably about 2 days prior to symptoms. That definitely presents a kind of tricky situation for everyday individuals to figure out their risk. And we also know from some basic modeling that if we do nothing, it's likely that about 60% of the population will indeed get sick. So given what we know about the dynamics of this virus and how it's transmitted, it's not likely that just finding and quarantining cases is going to work. And that's why a lot of people are turning to social distancing as the best option.
Thanks, Sharon. This is Laura Power. I'm a clinical assistant professor in the Department of Epidemiology. I'm an infectious disease and preventive medicine physician. Now that we have a better idea of what we are up against, we want to think about how we can lessen the impact and flatten the epidemic curve. Based on what is known at this time about the transmission of this novel coronavirus, there is concern about a rapid rise in illnesses and deaths that could overwhelm our healthcare systems. A recent study by the Imperial College of London estimated that the U.S. could have up to 2.2 million deaths due to COVID-19 in the span of a few months. This estimate is likely a worst-case scenario, assuming the disease spreads at the same rate across the country and assuming no social distancing interventions are in place. But with prevention measures, we can flatten the curve. The goal is to lessen the impact by spreading cases out over time and to minimize the number of cases overall, both of which will lessen the burden on the healthcare system and keep more people healthy. Right now, without a vaccine or medications, social distancing is the main strategy to flatten the curve. But does social distancing work? Experiences with measles outbreaks related to school sessions, shown in the bottom right figure, and experiences with school closings for influenza provide some support that social distancing measures work. And the larger the scale of the measure, like canceling sporting events, the more cases we can prevent. Thinking about social distancing in different categories, with normal behavior, we can expect in a population of susceptible people that the number of cases will skyrocket. But with social distancing, we can spread this out. With more aggressive social distancing measures, the curve will be flattened even more. To flatten the curve and mitigate the burden on the healthcare system, we want to decrease the infection reproduction number from 2 or 3 to less than 1. Both the gradual development of immunity in the population and the development of a vaccine will contribute to reducing this infection reproduction number. But it will be some time before we have a vaccine ready, possibly 12 to 18 months. So we can use non-pharmaceutical measures like social distancing to help flatten the curve while gradually building population immunity. We will need to have ongoing surveillance, like we do for influenza, to understand the situation and respond appropriately. And we will also need to study a vaccine when it becomes available to understand its efficacy and how well it prevents disease in the community, just like we do for flu. In the same study from the Imperial College of London, researchers estimated how different measures could help decrease the burden on the healthcare system. In these figures, the red horizontal line demonstrates the surge critical care bed capacity, and the blue shaded areas show the time period of the intervention measures. The lower panel of the figure, panel B, is more zoomed in so you can see more easily where the surge capacity is reached. If we do nothing, demonstrated by the black line, we hit the critical care bed capacity more quickly than if we do school closures and general social distancing. According to this study, though, there could still be a smaller peak in cases later after the social distancing measures end. And this study suggests that we could consider an approach called adaptive triggering, where certain aggressive measures are put in place based on what is happening. For example, if there are more people in the intensive care unit in a certain period of time, this might trigger more aggressive social distancing measures intermittently till we have other strategies like a vaccine and medications. But remember, this study is based on some assumptions that make this more likely to be a worst-case scenario. If we recall the SARS epidemic from 2002, it was difficult to predict what would happen, but it eventually fizzled out, and that could be a better-case scenario. So right now, we are focused on flattening the curve with primary prevention measures like social distancing and with secondary prevention measures like contact tracing, quarantine, and isolation. Surveillance for SARS-CoV-2, which includes testing people for the infection, will be very important for us to have a better understanding of the situation and will provide a better tool for prevention measures.
Thank you, Laura. I'm Emily Martin. I'm an associate professor of epidemiology at the University of Michigan School of Public Health. As we've talked about, there are a number of levels of preventative measures, and there are different measures that might be appropriate to apply at different times depending on the movement of the outbreak through different communities and as the outbreak increases or decreases at different times. In order to know that, we need test data. And so it's not a surprise to anybody who's been paying attention to the news that there's been a lot of concerns about testing rates in the United States. And there's been a lot of stories about countries that have done a lot of testing, like, for instance, South Korea that's done a ton of testing. Here in the U.S., we've done much less testing as there's been problems rolling out the tests into different settings. So I wanted to talk first about how we use testing to measure what we know about the virus, and then that data then goes on to inform what our strategies will be going forward as we deal with this epidemic. So, and I'm sort of capturing this under the idea of how do we know what we know. So in the very early days in Michigan of the epidemic, we had case counts that were much more limited, and testing was centralized at the health department at MDHHS in Lansing. And that they were working in coordination with the CDC in Atlanta to centralize testing, and that testing was prioritized to inform clinical care. So the top priority in these situations is to make sure that you are getting test data on those most in need of urgent medical attention. The second priority is to support contact tracing and quarantine efforts that are most useful in the early days of an outbreak to try to slow the contacts between infected people and uninfected people. In this scenario, there's a lot of rationing of tests, and tests aren't readily available even in a clinical setting. We are now moving into an area in March where we've got clinical testing quickly coming online in a lot of different local clinical and hospital systems. We also have a growing presence of commercial testing. Commercial testing is often provided by large corporations that have maybe local presence in different communities. Sometimes these tests are collected in different communities, but then sent to somewhere in the United States where they're tested and processed in big batches. And so that sort of transfer means that sometimes commercial labs have a little bit more of a lag time waiting to get test results. And so there's a growing movement to have more local testing happening at individual hospitals. So what we hope to move through as those testing efforts become more available is more testing at hospitals and clinics. And the goal ultimately there is that the tests will be available for everyone who needs clinical attention. And then that determination can be made by doctors in conjunction with their local clinical labs at their hospital. Then we move into the second goal of testing. It becomes appropriate to start doing what we call surveillance testing. So these are tests where we're getting tests in a sample of the population, and that helps us define the epidemiology. It helps us guide public health resources, and that gives us these kind of curve graphs that help us understand, is the is the pattern of the epidemic increasing or decreasing? Do we need to change our public health strategies? Do we need to change our recommendations for large gatherings in schools and things like that? And that surveillance testing is actually something that U of M and us at Public Health are very involved in. And we work together with the health department in Lansing. We work together with the CDC to be able to do that surveillance. So we've seen a lot of different models of test strategies. We've seen them all around the world. I think South Korea has been kind of famous for their very quickly deployed test strategy and their use of testing and then isolation policies to decrease the initial days of their local epidemic. But I think it's still important to note that even with a strategy that South Korea used, very intensive and expansive testing and isolation, they were able to decrease the epidemic, but it still hasn't come all the way down to zero. And so more measures are still going to be necessary beyond testing going forward to get this under control. So one common question as we think about looking into the future is what might we expect in terms of when are we going to resume normal activities? And unfortunately, the answer is that it's too soon to know based on the data we have right now. So we can watch other countries. We don't know yet how the experience in other countries is going to translate to the experience in the United States because of the unique density and kind of geographic layout that we have here in the United States. So we're also watching the U.S. government and the CDC decisions as they make recommendations and as people follow those recommendations that may change the course of the epidemic here for the better in good ways. And looking at the U.S. experience over the next several weeks will help give us a sense of how fast this is growing. It's expected that case counts now in March are going to jump up at a very, very high rate, both because the virus is spreading, but also because we're learning so much more about the virus and about the numbers of people that are infected as we deploy more and more tests. And so expect to see a big expansion of numbers in this period of time. Now, as we look to other countries for guidance in terms of how long this might last, one example is to look at China, which was the first country to have the virus circulating. In China, it was about a 2-month period after there were dramatic reductions in social contact that we started to see the rates of the virus come back down. It's important to note, though, looking at China's experience, that what China is experiencing now in terms of returning to quote-unquote normal activities don't reflect what we normally think of as normal activities. And so the resumption of activities still means that there are travel restrictions in place. There are people wearing masks in large numbers. There are a lot of efforts to use data and apps to monitor infections and people who are experiencing symptoms, and they still aren't having large gatherings. So as these individual precautions one-on-one kind of lift over time, you can expect to see that there might be changes of the virus beginning to spread again. It's too soon to know if that's going to happen. And so we're watching that to sort of know what to expect in the United States going forward. What we do know so far, though, is in terms of are we in the right position doing what we've done so far? And the answer is yes, that by doing the wide-scale measures of social distancing, which includes things like school and university closures and early day case isolation as much as possible, has the potential to delay what we're seeing right now to the point where it gives our hospitals and ICUs time to ramp up to the capacity that they need to deal with the epidemic as it reaches its full strength. And now Sharon is going to tell you more about some of the anticipated impacts of these important social distancing measures.
This is Sharon Kardia once again. Now I'm going to focus on the additional impacts of social distancing on our students, staff, and faculty. As we all know, social connection is one of the major ways that human beings cope with big difficulties and stress. And so with the movement to social isolation and distancing, what does it really mean for people's mental and emotional health? First of all, you can think about how losing social connection is going to exacerbate existing concerns and conditions, particularly for vulnerable groups of students, faculty, and staff who, for instance, are low income, are temporary employees, have the additional stress of being caregivers, or are very far from home. Many students are experiencing it right now in the ask for them to suddenly move. And inside of this, what seems like a good way to fight off the virus, the social isolation can really exacerbate already isolated and stigmatized individuals like the LGBTQ community, ethnic and racial minorities, as well as individuals with existing mental health conditions. Some of these are going to be not visible to people, and so it even sort of adds another layer of stress on that, increasing that potential for social isolation. And just to know that this is not going to be equally distributed across all our students, staff, and faculty. To put this in context, one of the biggest concerns is that it'll really influence mental health issues. We already know that suicide is a leading cause of death in college students, and there's a fair amount of suicide every year across the United States. From good data, we know that about 80% of students report that they feel very stressed on a daily basis. And some of this is also related to experiences of depression or diagnoses for other mental health conditions that are linked to anxiety. And that almost 10% of students have contemplated suicide in the past year. So this is kind of a staggering amount, especially for a large student body like the U of M. You put all of this together with the social isolation and social distancing, and it becomes a recipe for disaster in some ways. For instance, we know that 67% of students tell a friend they're feeling suicidal before anyone else. So that social connection is actually a buffer. And we can think of it as a protective factor that we ought to be considering. How do we find other ways for students to get the social support they need, even though we've gone remote? Loss of this in-person social network is going to lead to individuals sometimes exercising judgment that leads them to risky behavior, as well as to increased distress in the mental health area. Especially true for LGBTQ and racial and ethnic minority students who sometimes have less family support than some of our other students in the U of M. So what specific challenges might students face? Well, certainly the rapid transition and the loss of routine can mean that this destabilization, especially if they have mental health, I'll call it vulnerabilities, is going to be a major trigger. And that loss of social connection and community, especially for graduate students, many graduate students find their school and their peers to be their community. It also can raise concerns about uncertain housing, food, social and family support. I mean, in many cases, we have adults that are now transitioning home, and it can be an awkward or difficult situation that nobody really planned for. This reintegration with family, I think many of us can understand how it could be challenging to students. Certainly for students that have experienced trauma, there's going to be a re-traumatization in some of these cases. And we've now removed some of the access to counseling that they had here at the U of M. These challenges are going to be more acute for students with limited resources or those who are returning to challenging family situations or communities. So trying to figure out ways we might support students after this time period is really important. So we've come up with a little bit of a list of what we think U of M leadership could do. So for instance, frequent communications to support and connect through the summer. We recognize that students are getting a ton of communication from a lot of different sources right now. So we're not suggesting more communication right now, but during the summer, this also has some other benefits in terms of perhaps making them aware that they should have the opportunity to connect with the other students, both during this time and during the summer. Another consideration would be, can we find ways to provide mental health specific resources? Maybe telehealth kinds of access to mental health resources might be one way to help students. Nonetheless, even if we do all of this, we should be prepared for greater mental health needs in the fall as the effects are likely to linger. And we could consider things like, mental health first aid training or trauma-informed care training more broadly. And then thinking about things like a proactive focus on mental health in the fall across all the schools and colleges. We've listed out just a few of the mental health resources that we think ought to be pushed out to students as well as to staff and faculty as we're trying to navigate this very difficult terrain. Thank you for your time and attention to this presentation. This is Sharon Kardia on behalf of the School of Public Health.